Welcome, everyone. We have Dr. Meredith Holcomb with us today. She did both her bachelor's and got her doctorate in audiology from the University of North Carolina, Chapel Hill, and is currently the director of the hearing implant program and associate professor at the University of Miami. We are really looking forward to your talk. Thank you for joining us.
Thank you. Thank you for having me. I've been working in this space for about 20 years now. And I've worked with some of the great people who have come from the neurotology fellowships at the House Institute. Paul Lambert, of course, was my chair when I was at MUSC. Fred Talishi, of course, is the chair now. Teddy McCracken's a dear friend of mine, as is John Goddard. So, I've heard so much about this institution, and it really was just such an honor to be invited to speak to you all. So I'm going to be talking about improving cochlear implant utilization through clinical efficiency and equitable access. This can obviously look very different depending on what location of the US you're in, what patient population you're serving, but I'm hoping that you can take at least one or two tidbits away from this lecture and apply it to your own practice. For those of you who are in training, I hope this gives you something to think about when you are establishing your own practice. And or when you go to someone else's practice, how can you effectively change the processes in a positive way so that we can get patients through this journey a little bit easier. I have several disclosures listed here. So I always start with our team slide. I think it's really important to do that, especially when you're talking about change and efficiency. I was hired in 2019 at the University of Miami, and one of the reasons they hired me was because of some of the efficiency success I'd had at the Medical University of South Carolina. And when I came for, a little secret interview, right? The first time you come to give a lecture and you're just scoping things out. Two things. One, Paul Lambert, my chair at the time, was on my flight to Miami and he was connecting to go to a medical mission trip. So that was a little bit of an awkward conversation because he didn't know I was coming down to look at a job. But the second thing is, when I got there, what stood out to me the most, of course, we have a lot of physicians, we have researchers, we have a great team of audiologists. But what stood out to me the most were these people. We are really fortunate to have a family support team, which is probably one of the most comprehensive group of individuals of a team in the nation, led by Dr. Sejas, who's a psychologist and specializes in pediatric hearing loss. But seeing all of these people playing a key role in the success of patients, and we now have social workers who actually help with the adult population as well. One thing that stood out to me was as an audiologist, I was playing probably in some capacity all of these roles when I was in at MUSC. We didn't have these positions on our team, and so audiology really was taking uh, I guess, using a lot of the skills that we don't have or didn't learn along the way and trying to apply them for, IEPs, for social work, for navigating patients through this process. Seeing how this clinic, was, I guess, adequately prepared to take care of patients, it really enticed me to want to learn more about University of Miami. The group at the bottom, the clinical support, I have to say for any change that's going to be effective, you've got to have clinical support in place and you have to have people who not only answer the phones, but schedule the surgeries and are willing to play a role in different aspects of this patient journey that perhaps, the physicians and the audiologists just do not have the time to do. A lot of these tasks are non-billable. And when you think about practicing at the top of your license, engulfing yourself in non-billable practice is really not going to be sustainable for the organization. It's also going to cause extreme burnout for you as an individual. So think about how you can expand your team with some of these different disciplines. One of the ways that we've been successful with doing that is with donors. And sometimes if you just ask, they will happily donate for a position that will, positively affect change. So why this is all really important. I think pretty much everybody on this call knows that the World Health Organization in March of 2021 came out with something called the World Report. And it was really developed out of concern for lack of healthcare, hearing healthcare, and lack of treatment that was occurring across the globe. In all countries really, but especially low and middle income countries, there is a high need for hearing healthcare services, and there's just either not resources in those countries, or they do not have providers who are able to provide care. Hearing loss currently affects more than 1.5 billion people, and that's 20% of the global population. So, it is a global concern and something we need to figure out. But what we also need to figure out is how are we going to be able to accurately and appropriately and effectively treat these patients. Whoops. See if I can make a change. There we go. So, with the World Health Organization World Report, which if you haven't read it, I do encourage you to get it and to keep it as a resource. What they noted is not only is hearing loss projected to substantially increase from now until 2050, but what we also notice is that while the majority of patients have mild hearing loss, really there's still a substantial portion of patients, or about 430 million patients, which is about 5% of the global population, that experience moderate or higher levels of hearing loss. I think all of us know that if we leave this diagnosis untreated and undiagnosed, there's going to be a lot of impact on patients' daily activities, their quality of life. There's also, of course, we know been some links with dementia, with anxiety, depression. So it really is a concern in more parts of our health than just hearing. But how can we make a change? How can we do better? You would think the US, which is a country with a lot of resources, you would think we would be doing a pretty good job of diagnosing patients and getting them through our system. Um, what we're not doing is a good job, right? So it's taking about 7 years before patients even seek help, meaning before they even get to an ENT or an audiologist in the community. You guys are set up very similar to us here at University of Miami, where we have a lot of neurotology specialists here. So oftentimes patients are not coming into our doors until they have been seen by an ENT in the community and then referred on for specialized services with our surgeons. Not only is it taking about 7 years for patients to seek help, but then they get stuck in that cycle of general ENT or an audiologist who is continuing to fit hearing aids. They can be in that cycle for about 10 more years. And this is for adults, right? And so thinking about, family members that you have, 17 years that they may wait on cumulatively to get the appropriate treatment for their hearing loss is really is sad. It's a long time to go without effective communication with your family and friends. This is obviously a huge concern for the adult population, especially when you get into your elderly group. And, as they age each decade, we see that the prevalence of hearing loss doubles. But we don't see that that population is any more successful in getting treatment for hearing loss. So, less than 30% of patients who have mild to moderate hearing loss are treated and receiving care. Okay. And that may not be the population that you worry about quite as much. Of course, with a cochlear implant population, this is not necessarily the population I might be serving. But what we do know is that the degree of hearing loss doesn't necessarily correlate to how much difficulty they are having with their hearing loss, meaning somebody with mild to moderate hearing loss may be struggling just as much as someone with severe hearing loss subjectively. About 50% of patients who have a more severe hearing loss are treated with hearing aids. And what's really concerning is, greater than 70% of severe to profound sensorineural hearing loss patients are treated with hearing aids. But that's hearing aids. It's not with cochlear implants. So while the severity worsens and the percentage of patients who are, in hearing aids, that number increases. Really, we still see poor device utilization rates overall, and we also see poor adoption of hearing aids as well. If you look at the numbers on more of a bigger scale, instead of breaking it down into those severity of hearing loss, less than 20% of patients who need hearing aids have access to them. This is for the adult population. And for cochlear implants, we've seen reports as low as 2% and up to 12% of patients who need cochlear implants are using them. What's also concerning is that hearing aid sales typically are to existing hearing aid users looking to upgrade technology. So new patients are not coming in our doors. And so why is that? And how can we do something within our own program to make this better? How can we open our doors to new patients and stop spending all of our time on existing patients? You would think for children with the 136 that we would be doing a better job of appropriately treating hearing loss and making sure that we are efficiently and effectively getting them what they need. Recently, the JCIH position statement even suggested that we should be identifying, diagnosing, and amplifying children within 3 months of age. You can always look at the annual data from AuD in your specific state, which I encourage you to do. I did this for Florida and it really kind of blew me away. I'm actually the co-chair right now for the JCIH committee. And the reporting mechanisms for each state is varied. It's not consistent. And while each state maybe likes to think that they're doing a good job, they probably are not. So when you look at this graph, you can see the US 1 month benchmark and the state 1 month benchmark for Florida. This is specifically for Florida. We're not doing a bad job. So we're actually screening children pretty early, which is great. That's great. They should be screened. If we know they refer, we should be getting them into an audiologist who can do a diagnosis for them. But when we start to look at the actual diagnosis numbers, the US benchmark, so remember, we should be closer to 100% on this, right? The US benchmark is somewhere around 50%. So about 50% of children are getting a diagnosis by 3 months of age. And in Florida, it would look like we were doing a little better before COVID and then never really quite recovered. So, we're doing worse than the national average. Thinking about early intervention, getting children into either a hearing aid or by 6 months, we're implanting a lot of these kids now. We're doing a horrible job there as well. So for the state of Florida, we're less than 40% of children who need amplification, early intervention, cochlear implant services. Less than 40% are being appropriately treated in a timely fashion. We looked at this even with our own institution. We had just had a paper that was published this month. We looked at congenital sensorineural hearing loss and how children were getting through our system. And again, kids are typically coming in to that first visit, first University of Miami visit. They weren't getting in our doors until about 2 years, a little over 2 years old. And they were just being passed around either by, other audiology practices, or maybe they were lost to follow-up and then showing back up once they are not talking. But we did not have control of the newborn hearing screen program here in South Florida at the Jackson Hospital, which is an enormous hospital down in Miami. So you can see our time to surgery, we're doing a pretty horrible job here. Our average age of implantation is about 3.5 years for children. I think this is going to change. We have some early data right now since we hired a patient navigator for the pediatric program. And we have consumed all of the newborn hearing screen program now for Jackson Hospital. And we are getting children in the door now before they're 1 month old. And then there is only about a 9 month period between their first entrance into our system and when they're getting implanted. So we're already seeing a big shift in those numbers. But my point is, a lot of places look like this. Australia does not. They do a great job. 97% of their kids are being implanted on time. In the US, about 55% of kids who need implants are getting them. So, thinking about the adults and the pediatric population, which I think we all have interest in serving the lifespan, there's a lot of key factors about the assumptions for why we have this problem, which are all listed here. But a lot of it is just low awareness and lack of appropriate referral. And thinking about the appropriate referral also leads you to think about how the patients are getting through the journey. And then is there something that we could do from an efficiency standpoint to make this better? Ashley Nasiri is a good friend of mine. She's at the University of Colorado. And she's written some really great articles about the patient journey, especially for cochlear implants. Specifically, one of the articles she wrote in 2021 outlined the every step of this sort of process map of what the patient goes through. And as you can see, it's a lot. It's up to 16 steps from the time they are evaluated by a PCP and then referred for a hearing test, get a hearing aid, so forth, and then finally get into our doors. And really, the navigation of this healthcare journey is time consuming for patients. It's a reported barrier for care access. It's often requiring more than 10 pre and post-operative visits just in the cochlear implant center at some locations. And, even though I think a lot of conferences we go to, we hear people say, oh, we're at capacity. We have a 6-month wait for a patient to get in for an implant eval. We've got to do a better job of this, right? So we've got to figure out a way to get to lessen those extended wait times for CI appointments, because the number of people who have disabling hearing loss is just going to increase. And if we continue implementing, this outdated scheduling process and this outdated patient journey protocol, we're not going to be positioned very well to handle the care of these millions of adults and children who could benefit from this technology. Now, if there's any audiologists on the call, and I'm sorry, I cannot see faces or names. I know one of our externs is on the call right now who's an audiology extern. But, from an audiology standpoint, sometimes we get frustrated because surgically, I think the misconception is that patients are just getting stuck in audiology, or it's taking too long to get from, through the CI eval process into the OR. But really, there's a lot that we're having to deal with from an access standpoint as well. And this, of course, is patients getting in to see you guys in your clinic. So distance to the CI center. Here in South Florida, we are probably in like one of the most southern places you could be in the US. And so a lot of our patients are having to drive farther away. We also have patients coming from the Caribbean, and they're having to travel in for care, and the coordination of that can be quite extensive. There's unclear clinical protocols. We're trying to do a better job as a group right now. I'm on a couple of task force with some key individuals for cochlear implant audiology, and there's really a focus on making clear clinical protocols for audiologists to follow. And they're, thinking about if we can finally get these protocols in place and make it a pretty clear process for how patients should get through this journey. If audiologists and physicians are not adhering to some of these protocols that are going to be best practice, is there a medical error that's occurring, right? So I think about, if audiologists know that we have clear protocols that, have evidence to support why patients should be at least referred for the CI testing, and they're not doing that, they are responsible for the fact that these patients are not getting what they need. More to come on that. Still, as you guys know, it's not easy to make big change in this community. There's a lot of misinformation about the CI process. ACIA has done a really good job of trying to get better information out there. But still, on the Facebook chat groups, if any of you are involved in the Cochlear Implant Experiences chat group, there's just a
Um,
lot of, sorry? There's just a lot of bad information out there. One of the other things is staffing concerns and limited clinical space. So for audiology specifically, we need a booth, right? And a booth is not a cheap piece of equipment. And so we're trying to figure out ways to get these patients more quickly through these processes without compromising patient care, but also without overutilizing clinical space that could be used for something else as well. So what happens is, of course, what we see is bottlenecks. We see short-term bottlenecks, long-term bottlenecks. We try to come together as a group or a team and figure out what is the solution for a bottleneck. Sometimes we can, throw things at a wall and see if it sticks, which can be very frustrating. I would recommend using a very systematic way of looking at what a root cause is for the problem. It's often a little bit alarming what the actual root cause is compared to what all of our assumptions may be. But what we don't want to happen is we don't want these bottlenecks to continue to cause backlog of work, dissatisfied patients, unhappy staff, where people are, deciding this is too much, I'm burnt out, I'm just going to go work for the industry or somewhere else. And then the long wait times and delays for patients, I think the longer patients wait, the less likely they are to want to come in and appropriately treat their hearing loss. So how does this look for the University of Miami? When I started in 2019, one of the first things I looked at is how were we doing with our cochlear implant surgeries? Were our numbers increasing, which is what you want to see with the program. You want to see that you are consistently making space for new patients. You're consistently finding a way to positively affect more people in the community with this amazing technology that we all know works, and it really can be tremendous for patients. What I noticed very quickly is over the course of the past 3 or 4 years, we had instead of seeing a growth, we had been seeing a decline. This was not because patients weren't coming in. It was because we were not scheduling patients correctly. We were over scheduling patients who had been implanted already. Um, we had two audiologists who were refusing to see new patients because they said their schedule was full. And so this brings up kind of an interesting conversation, because these providers said, well, we're productive, we're busy. You are productive and busy, but you're not efficient, right? So the program is declining, which is not a good thing. Patients can't get in, which is not a good thing. And so we have to figure out why that is. I always recommend at least looking at where you are compared to other places in the country. You can learn a lot from talking to your colleagues at other clinics. This is one of the first things we did as well. So we looked at how many surgeries were each clinic performing, and then what was their cochlear implant FTE. So for audiology, what that means is for me, I'm in clinic 3 days a week, right? And I have some research time, I have some admin time, but 3 days a week is devoted to cochlear implants. So I am considered a 0.6. So you do that with every single audiologist on your team, and then you add up what the cumulative FTE is. What we saw is there were several clinics that were pretty similar, and then there were two that were concerning, us and Clinic E. Clinic E was doing 120 surgeries a year. They were doing more than we were. So I think a lot of people thought Miami was a program that was doing 250, 300 implants a year, and we actually were not. But this clinic was doing 120 a year. And the total FTE that they had was 1.5. Okay. So they were probably pretty overworked. This clinic was 300 a year, and they had a 5 FTE. They were doing a little bit better, probably better staffed. And then when we looked at our clinic with 110 surgeries a year, we actually were staffed almost as well as Clinic A, but our numbers were, Clinic A was almost 3 times the surgical numbers that we had. And so what we figured out very quickly is we had a lot of resources that we were not using appropriately. And then when we looked at how much time our audiologists were spending on new cochlear implant patients, evals, and activations, compared to existing patients, it was quite alarming. So the bulk of the pie, as you can see, was spent on patients who are established. And what we know from the literature, especially now, is these patients really, their performance doesn't change drastically after about 6 months of having their implant turned on. But we were seeing these patients repeatedly. Okay. So a lot of room for improvement. But, you make goals. These are kind of overarching goals. But then you have to get the team on board. And that is not an easy thing to do. It took probably about a year, almost a year and a half, I think, to get everyone on board with some changes that we had implemented. I will not tell you that it was easy. One of the first cochlear implant meetings that I led, two audiologists very loudly walked out of the meeting and said that they weren't going to do this. The surgeons were very kind and supported the efforts. The audiologist eventually came around. But it's difficult to change policies and procedures that have been in place for several years, and especially if there hasn't been a lot of oversight on how the team was operating. So again, Ashley Nasiri, I love this quote because it really makes you think, for long-term success, expansion of CI services will likely require a combination of strategies to maximize resources and mitigate financial risk. And she has examples for coordinated care, reduced number of appointments, telemedicine, remote programming, thinking about where you actually are seeing patients. Is everyone having to come to LA? Do you have satellite offices in other areas of California? And then how can we partner with industry to make our efficiency better? When I read this article in 2021, we had already started some of our changes, and I was actually very, very proud of us that most of the changes we were making fit into these buckets, into these categories. But I think this is a really important slide, and her paper is a very important paper that makes you think about how you can improve your processes at the place where you're seeing patients. Um, what I'm going to talk about next is really what we did, and we did a lot. We looked at, how we implemented sort of a new service delivery model. We wrote a paper on this. Molly Smeal, who now is at Hearts for Hearing, working with Renee Gifford and Jordan Holder, she was really instrumental in helping me get all of this going and move it forward. She is younger than I am, and so now that I'm in my mid 40s, having young people on your team who are really motivated for this kind of topic is great. They know usually way more than us older people about how to be efficient with everything. But we ended up writing a paper on this with Otology Neurotology. Very kindly accepted it, but I'm going to go through what we looked at. So one of the other concerning things, we wanted to look at what our conversion rate is. So ideally, you don't want a low conversion rate for how many patients are ending up in the OR compared to how many you are evaluating. If you're evaluating a lot of patients in your practice, as all of you know, for any surgical treatment, and they don't end up in the OR on the surgery table, you're doing a lot of clinical work, and then there's not a lot of revenue that comes from that. So we want to be selecting patients who truly want to go through this evaluation process. What we were finding is, the physicians were referring patients in their practice saying, okay, Johnny, you need a cochlear implant. I'm going to send you to the cochlear implant team. And they would just get scheduled when they checked out. So Johnny would come in for his cochlear implant eval. He would have no clue what a cochlear implant was. He also didn't want surgery. And when we would show him the device, he would say, that's not for me, and he would leave. So now our audiologist had 3 hours of blocked time to do an evaluation and counseling, but the patient was not interested. And so that time we couldn't bill for it. And also there was no productive movement for this patient moving to surgery. Um, what also was a little confusing and complex and created a lot of, really a disaster, was our decision tree, which was, as you can see, lots of arrows going in lots of different directions. And who was monitoring this? And did we expect the surgeons to remember all of this when they were referring patients? When they referred the patients, was the scheduler supposed to remember this? We really had no system in place at all to manage that flow from the referral. So now we have a very streamlined process, and each of these steps has really created a much better flow for the patient, more communication with our team, and we have better conversion rates, which I'll show you in a few minutes. Most patients, Dr. Holder wrote this in 2018, most patients still look like traditional candidates, right? But that was in 2018. In 2019, the FDA criteria changed and SSD became a big part of our clinic. About 20 to 25% of our patients coming through our clinic have SSD or asymmetrical hearing loss. And so referrals look a little bit different now than they did back when I started in cochlear implants, when everybody was severe to profound. So we looked at our referral process. Were there things that we could change? One thing we needed to do was implement trainings for the entire team, the nurse practitioners, the family support team, anybody who had even just a hand in the patient journey. We needed them to be up to date on what candidacy was and what it looked like and how to identify potential patients. We also started doing a case review series with the audiologist, so they could have practice looking at audiograms and identifying patients more easily in their clinic for ENT audios. And then we also implemented a subcommittee. So we have once a month, we have a hearing implant program meeting. That's with the entire team. It also includes, our staff, our family support, educational specialists, all, social worker, all of them. And we use that for topics, kind of key topics that are emerging in cochlear implant care. We don't review as many cases in that big group because of the kind of the large group of individuals that's on the call. But we implemented a subcommittee, so on the off every 2 weeks that we don't have the big hearing implant program meeting, we have a subcommittee of a social worker, two audiologists, and two surgeons who meet and talk about borderline cases or cases that we're just not sure what to do with. And that's become so popular that we have to rotate who's on the subcommittee because everyone really likes being part of it. And it's become a really good training opportunity for our trainees when they come through. So then we thought, okay, we've counseled, we've educated on how to correctly identify the right person for technology. How do we make sure that the patient is then scheduled appropriately and triaged? So we set up a patient triage system in Epic. I'm not sure if you guys use Epic. We established pools. So with a pool, you can, as a physician, you can send the chart to this pool, the hearing implant program pool, and then you just need somebody who's identified in your program to watch the pool when the cases come in. They review the audiogram and the criteria for this patient and whether or not they would be better suited to move through the cochlear implant process, to move through the SSD process, which is we have a little different group that does that, or for a bone conduction device or a hearing aid. We have two audiologists who manage this hearing implant program pool, myself and then one of the junior audiologists. It's a lot of fun. Not everybody wants to do extra work, but to me, it challenges me. It makes me think about how, I'm going to treat other patients in the future. So it's been a really good learning opportunity for me. So we quickly triage the chart. It doesn't take very long. And then we actually do a chart note, a documentation with a smart phrase that is extremely quick. It's going to show you here. We just very quickly, F2 tab over, decide which evaluation is necessary. This then is picked up in a work queue by our schedulers. So the schedulers know instantly what this patient needs to be referred for or has been referred for, and they go ahead and schedule. This process has been a game changer for our team. And it's really been a game changer for our patients, and we're able to track the patients as they come through this pool. So we can be sure that patients are not lost in the shuffle from, leaving the physician's office. And then do they get scheduled? Do they just decide they don't want to wait in the line to schedule? So this is a way within the electronic medical record that we can manage the flow of patients and reduce loss to follow-up. Benefits of triaging so far, it's really limited inappropriate referrals. So if we see that there's one provider who's recommending cochlear implants for patients that this is, not the right technology for, then we're able to go back and re-educate that one provider. When CCC-A came out and nobody seemed to remember that Medicare Part A and B does not authorize this, and it actually is against their candidacy criteria. There was quite a bit of going back and forth with the surgeons to remind them this, we got to look for Medicare, you got to look for the insurance. Now we really don't have any of those issues, but it's also improved the tracking of our scheduling steps. It's improved the confidence in non-traditional referrals. Our hearing aid audiologists get really excited when they refer somebody who's non-traditional, and then they'll come tell us, like, I sent you this chart. I hope it's not a bad referral. And the girl who's doing this with me, Dr. Toledo, we both are like, look, there's no bad referral, right? It's an educational opportunity for the patient to learn more if that technology is appropriate for them. We also started using Epic templates and smart phrases. This seems like that would be, not something you'd have to discuss with a team, but when I came in, the audiologists specifically were free writing all their visit notes in a Word document and then they were transferring them, like a copy and paste into Epic. So Molly and I came up with, I mean, we have templates for literally anything that you could think of. And the benefits of that are, efficiency, standardization, reminders in the template of things that you should ask. We have a QI project that we just completed with one of the neurotology fellows for patients who are presenting pre-op with dizziness or vestibular concerns. And what we found is we're doing a horrible job of referring them for a vestibular evaluation, or even documenting in the medical record about some of the symptoms in the CI eval. So there's little things that these templates can do to make us better clinicians, and to provide patient-centered care. And then, of course, if you do a retrospective review at some point, these templates can be quite convenient for data collection because you easily know where to look for things. We found that from using these templates, we decreased the documentation time from about 30 to 45 minutes per patient for audiology, down to no more than 15 minutes per patient, which was a huge non-billable time saver. The next thing we did, because 2020 occurred and we couldn't see patients as easily inside our offices, we started playing around with telehealth. So we implemented telehealth in the pre-op journey. Before, our old pathway was, they came in through ENT, audiology referral, and then they were scheduled for an in-person 3-hour visit for counseling and evaluation and device selection all in one. And then they moved on to the surgery. Now we were going to try out something different because it was more challenging for patients to bring someone with them to appointments. We had very strict guidelines. So we wanted to implement a telehealth counseling opportunity that would occur before the evaluation. It really was appropriate for all ages, for pediatrics and for parents. We found that even up to a 94-year-old man was the oldest person who engaged in this. But he had his whole family there. It was the day after Thanksgiving, and he was 2 hours away. So it expanded the geographic reach that we were getting. We found that patients were really loving this experience. They would make comments like, this is great. I feel less stressed because I'm not in the office. I was afraid you were going to wanted me to make a decision about whether or not to do surgery today. We also use captions with this, and what we found is that it also increased the likelihood of decision making at the in-person CI evaluation. So we use a PowerPoint presentation. It's about 10 slides. It's great. Students and trainees can learn how to do this. It's really wonderful for them to become more effective with how they're counseling patients about this process. And with the PowerPoint, it allows all of our team to be providing the same information. Of course, you can go off script if necessary, but there are certain things in the PowerPoint that we wanted to make sure was hit with every patient. There's a lot of research out there with unrealistic expectations that patients have. My friend Teddy McCracken has done a lot with that. And so, this is a way for us to try to make sure that realistic expectations are set on the front end. As soon as they leave the telehealth, we then send them through Epic a letter, or like an electronic letter. And it has the next steps. It also has a link to questionnaires that they'll complete, so that we can get a more patient-centered, well-rounded view of like how the hearing loss is affecting them. Oops. And then we also include videos from ACIA about the CI process, and then direct links to the company websites so that they can get more information on their own, and we really encourage that. Likewise, if they decide or they tell us in that appointment, hey, I already know that I want a cochlear device because I heard about the Nexa, then we'll also send them information specifically about that company and some good information about how they can contact Cochlear directly to go ahead and start the educational process on that specific company. Again, really using the company as much as we can for some of this non-billable work. So then we looked at, did the telehealth work? Some of our clinicians were not convinced that this was an effective way to provide care. We reviewed 582 charts. And what we found was that there was no difference in the time from the initial referral to the CI evaluation. So that was good. It wasn't adding any additional time in the patient journey because we know the journey is already long. It did decrease our no-show rate for the CI evaluation by about 5%, which 5% is not a ton, but I'll take it. At least there were less people not showing up to the evaluation in person. The biggest thing that we saw is that with the inclusion of telehealth, our conversion rate from the evaluation to the surgery almost doubled. So where we were at about 48% for conversion rate for looking at all of these charts over that time period, with the telehealth group, 83% of those patients converted to surgery from the evaluation. So much more effective use of all of these appointments and our team's resources. And then the other thing we noticed is that patients were actually getting to the OR faster. I can't tell you exactly why that is, other than maybe they were just more motivated because they were counseled well. We did have patients who they would go through the telehealth counseling and they're like, you know what, this isn't for me. No big deal. We would end the telehealth. The telehealth was about an hour. I tried to get it less than 30 minutes, but our average time is 48 minutes for the telehealth. So I couldn't really ask people to do it much shorter than the hour. But that's okay. If they choose not to come in, we just tell them to contact us if they change their mind. I mentioned that families could attend. It really reduced the burden of traveling to the clinic. You can pull in actual live interpreters for this, which is awesome. We, the other day, had an ASL interpreter for the patient in question. And the patients came with a family member who the family member was like, oh, no, 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 I can just, I can do the information and then we'll make sure that he understands. But the family member didn't sign. So we pulled in an actual person on the screen in the Zoom who was an interpreter, and it really made a huge difference. I mean, the smile that came over the gentleman's face when he had someone who was speaking his language was really important. We also had someone who was Creole on Monday, speaks Creole, and we had an interpreter for that too. Using live captioning, it's been amazing to use captioning in these appointments. I actually use live captioning in most of my appointments for patients who are struggling with communication. You can do it as an app on your phone, or you can just pull up a blank slide for PowerPoint, and then you can do the captioning at the bottom. We've also found that clinicians really loved doing the telehealth. And the reason is that they were now seeing people in the eval who really wanted to be there. And that I would get these comments like, oh my gosh, this is so much more fun now. I'm actually, testing patients and seeing patients who want this technology. So that was something I didn't anticipate. And then I mentioned the conversion rate. So if you break that up into the years from 2019, when I started, 2020 is when we started implementing the telehealth early on. You can see that our conversion rate really has stayed pretty steady. And it has not ever gone back to the 58% that it was before. Um, Ashley and I and others did a paper in 2023 looking at catchment area for cochlear implants. There were 7 US centers that were involved in this. And what stood out to me from this paper, even because I guess we had done the data collection was through 2020. But 43% increase in CI surgeries were seen between 2015 and 2019 across the board for all 7 centers combined. But when I looked at our specific numbers at UM, we actually saw a 16% decrease in surgeries during that time. So, I thought we were really headed in the right direction with some of the changes we were making. Looking at the data from this, about 52 miles each way was the median for miles traveled to the CI center. Of course, those who were at rural CI centers traveled greater distances. And 91% of patients lived within a 200-mile radius, but really 71%, so the bulk of the patients lived within a 100-mile radius. And looking at our population and our clinics, we're spread on the yellow stars. We're spread all the way down to South Miami up to Boca at that point when we had been doing this data collection. The red circle is the 100 miles radius. Excuse me, the 200-mile radius. The 100-mile radius would be somewhere north of West Palm Beach. So because this radius was, in the data collection showed us these numbers, what we decided to do was to start providing care at West Palm Beach for cochlear implant programming and evaluations. If you've ever been to South Florida, Boca Raton and then north of Palm Beach is where a lot of the retirees live. There's really great small places. Vero Beach is one of them. These small communities, lots of retirees, but we were not capturing much of that population. We had some competitors in the area, but really they were having to travel too far. And if you've ever been on I-95 in Miami or in South Florida, it's a nightmare. I worked with one of the hearing aid audiologists, trained him how to do the CI evaluations, and then I started coming up to Palm Beach 2 days a month to provide care. And what we noticed is once we opened the doors, the patients started coming in. So we saw a significant increase in this service line, and I'm actually booked out about 3 months at a time right now for CI programming in that office. So we're really now looking at how can we get someone in the Palm Beach area more days a week to provide CI care. The other thing we looked at was our appointment schedule. So this is sort of what the appointment schedule looked like in 2019. We had 90 minutes each for these appointments. This is a lot of appointments for a patient in the first year. On top of that, if you were a unilateral CI recipient, the team at that time was dividing the CI programming and the CI testing on 2 different dates for each of those intervals. If they were a bilateral patient, they were separating the programming for each ear and the testing. So now 3 times that patients were coming in for each of those intervals. The reason for this is because they didn't understand billing and modifiers. We've worked all of that out now. But look at this. I mean, if you were a bilateral patient, you were coming into the University of Miami 16 visits in the first year, or spending 24 hours of your time strictly coming in to these appointments. So we changed this appointment schedule. Everything was going to be performed in the same appointment, and we reduced it down to 4 appointments in the first year. And that was 8 hours that the patient would have to be in the office. What this shows is the blue is the number of the number of appointments seen for established patients, and the purple is new patients. Excuse me, opposite. The purple is the established patients, and the blue is the new patients. So what you're looking at is a steady decline in the number of visits that we were using for established patients, which was great. It means we were going to be able to see more new patients and make use of getting patients to this technology. The other thing when we made this change is it opened up 20 weeks of cochlear implant appointment slots. And so we had the floodgates opened, and we were able to accommodate many more people into our clinic. Lena Asfor, who was our neurotology fellow this past year, she's taken a job at NYU. We are in the middle of submitting our revisions for this publication, but we looked at whether or not patients actually adhered to the reduced appointment protocol. So it's great if you make these changes, right? But then you've got to look at, were the changes effective, and did your team follow through with it? So we looked at this from July 2022, which is when we implemented the new protocol, to the end of December 2023. And we looked at children and adults. We excluded anybody who had a reimplant, explant, or revision. And this was only for patients who were newly implanted and had gone through that 1 year of appointment schedule. We collected a lot of things to look at this, including CNC word scores at the 12-month mark, just to make sure patients who adhered to the reduced schedule were not performing worse. They did not perform worse, they performed the same. Most of our patients were adults for this retrospective review, about 72%. The rest were children. And there's a, kind of a nice spread there with insurance, with the majority being private insurance. And a nice combination of non-Hispanic and Hispanic patients for this as well. What we found was that in the first year post-surgery for this review, over 50% of patients were adhering to the 4 visits or less new protocol. And that was great. So we had, another 12% who were requiring 7 to 10 visits. When we looked at that more closely, Some of those patients already had their surgery scheduled, and their first year of appointments were also already scheduled because that's how our team does it. We schedule everything at once. So we think that probably the provider did not then go off the old protocol, and our surgery schedulers and our appointment schedulers also did not make those changes. But for the most part, we were pretty happy with the 53%. When we broke this down into a compliance rate, you can see kind of a steady improvement through each quarter. For quarter five, 67% of patients were adhering to this new protocol. We're not sure what happened in quarter six because it dropped down to 52%, but regardless, that just could be an outlier because overall we were seeing a pretty good adherence to this new protocol. We also looked at like age, gender, ethnicity, race, device manufacturer, electrode. We looked at audiologists. And what we found is none of those factors had an effect on the compliance rate. But what we did find is that those patients with Medicare, so those are the 65 years and older, or patients who have a disability that requires them to be on Medicare, they were 2.22 times more likely to wait a minute, that's not right. They were 2.2 times less likely, that's an error. They were less likely to comply with the visit schedule. So we want to look at that a little bit more in detail and try to figure out what that actually means and why is it that there's a difference with the insurances. So back to the surgical numbers, we started all of this in 2019. You had seen that decline in how we were doing. But now, at least as the end of 2023, I don't have 2024 on there, but we are continuing to see a sharp increase in the number of patients that we're able to appropriately treat with cochlear implants and can make use of this technology. We saw an 83% increase in our surgical numbers, and for the first time ever, we hit 200 surgeries a year. So we were really excited about that. We are hoping that we can continue this climb. Unfortunately, we've lost a couple of audiologists. We've had a huge problem trying to hire people. This is Los Angeles is the same. This is one of the most expensive places to live in the country right now. So, I think if we can get more staffing or more clinical FTE for CI audiology coverage, then we're going to continue to see an increase in our surgeries. From the numbers that we had calculated, we need about a 1 FTE per 50 surgeries in order to continue to grow. And right now we're a little below that. So 2024 was a little bit less. We did a few less than 200. And this year, I think we're going to end up doing more than that. But again, we're going to be limited in what we can do with limited resources. So our outcomes, huge outcomes, we thought, increasing profit, more surgeries, reduced wait time for appointments, decreased no-show rate. We increased the number of new patients that were accessing hearing services, and we opened 20 full weeks for CI appointments. So, we were proud of all of this. It's not to say that we did everything right the first time. There's still things that we want to change. We're tweaking our processes and our workflows all the time. I actually just sent something this morning about a workflow for our scheduling of initial activations and where the kits are going to be shipped to. Because we had a problem with kits not getting to the satellite office, and we've kind of figured out what we think the root cause is. And so we're going to put something in place to address it. But, by and large, in conclusion, hearing healthcare and treatment options really are underutilized, severely underutilized for people who need it. Audiology, ENT, CI centers, we all have to be extremely thoughtful about service care delivery, and especially because there is going to be this increase in number of patients with disabling hearing loss that need access to us and our care. What I will say is if you execute things well, and if you use a systematic approach, to put solutions in place. And if you examine your productivity and efficiency with the team, then you can have a positive impact on your program and your patient care. It's not always fast, and not everybody is going to be excited about it. But once you start seeing the change and it is positive, I think people tend to get on board a little quicker. Clinical care models need to be adapted now. We need to think about this now in preparation for those potential rise in the number of CI candidates coming through the door. If any of you going to, leaving training and going to other centers or even there at house, if you have not taken the ICIT team efficiency course, I recommend that you take it. The late Tom Balcony, who also was a neurotology fellow at House, when he retired, he started the ICIT course out of the need to educate more surgeons at that time about cochlear implant surgery. That has now just been an explosion of courses for audiology, for speech pathology. And one of the ones that I'm involved with is the team efficiency course, which has been an amazing 10-week course on lots of leaders in our field about how to improve your efficiency. For this course, you would have a surgeon, an audiologist, and an administrator. And so it forces you to team a little bit with those individuals and to learn about best practices for improving outcomes and patient experience. For any of you, if you ever want to meet privately when you get to your respective positions after you're done with your training, please email me. I've met so far with, I don't know, probably 10 different programs about how little things that they can do to affect change. I'm happy to meet with your audiology team as well. So anything that I can do to help, I'm more than happy to do that.